Hi there, I'm Dr. Brian Hill. I'm the director of the Lymphoid Malignancies Program at the Cleveland Clinic, Taussig Cancer Institute. I'm joined now today by Dr. Jacqueline Barrientos from currently Northwell in New York, but soon to be Mount Sinai Hospital in Miami. She's a CLL expert, and on behalf of CLL Society, I'd like to welcome you, Dr. Barrientos.
Hi, thank you so much. And I'm going to discuss my abstract. It's a pleasure to be here on behalf of my co-authors on the application of the National Comprehensive Cancer Network Clinical Practice Guidelines in Oncology for CLL, SLL from the informCLL Registry. So our registry was designed because the treatment paradigm for patients with chronic lymphocytic leukemia and small lymphocytic lymphoma has evolved so quickly over the last few years with the approval of the novel agents and an increased understanding of the impact of this prognostic marker testing. We decided to do a prospective analysis and registry that included patients treated both in the community and in the academic centers. So the way that we designed the registry was to include anyone that would require therapy within the next 6 months. Anyone older than 18 was allowed and eligible to participate. And it included about 1,500 patients. So we had a little bit over 1,500 patients, and then some of them were found to be not eligible or they were not receiving an FDA-approved drug at the time of the participation, so they had to be taken off. We ended up having about 1,462 patients, 1,462 patients in total.
This is a registry, right? So
yes.
Maybe you can kind of share what, with the audience. A lot of patients out there may not always be as familiar what we mean by what exactly a registry like of this size would be.
So informCLL is a US-based multi-center prospective observational registry that essentially offered to the patients that were about to start initiate any therapy the opportunity to participate. They would just register with the registry, and then the patients will be prospectively followed up in clinic, and all their data would be acquired during the visits. And that would include to not only the time of the diagnosis of the CLL, but we would also incorporate the analysis of any biomarker testing that was done at the time of the registration into this trial participation. So it's a unique opportunity for us to evaluate real-world CLL treatments and the treatment practices, not only in the academic world, but also in the real practice setting, in the private setting.
So this is not actually a clinical trial. This is more of an observation of just sort of describing the practice patterns across a large group of patients with CLL across multiple centers in the United States.
Yes.
Okay, got it.
And if performed at the time of the registration, we would also acquire the data of prognostic marker and biomarker testing results. And the reason why this is so important is because over the years, we have learned that patients that have high-risk markers such as 17p deletion by FISH analysis or TP53 mutation by next-generation sequencing would not benefit in terms of response rate or overall survival if they're treated with chemoimmunotherapy approaches. These patients should be treated with novel agents as per NCCN guidelines.
Got it. Okay. And so what were your findings?
So we compared all the patients started to be registered in the trial as of October 2015, and they had to be followed at least for 24 months. So we found out that the majority of the patients were essentially treated in community setting, so more than 90%, with a minority of the patients treated actually in academic centers. And because the NCCN guidelines change over time, we selected the NCCN guidelines that were accepted in 2017, because 3/4 of the patients were actually treated in the year 2017 or later. And so we divided the patients that registered in the trial by score of comorbidity index. Comorbidity is when you have a disease of, for example, hypertension, diabetes, renal insufficiency, cardiac disease, cardiac arrhythmia. So all those things make you more frail. So if you have 3 or more comorbidities, you are at higher risk of developing complications from your therapy. And so we just wanted to look at the data of who were the patients participating. And we selected 3 different groups. One was the group of patients that were elderly and frail. The other one, the group that had that were elderly and had no comorbidities, and the other one was the group of young and no comorbidities. So the majority of the patients that participated in the trial, like 58%, were untreated, and the rest were relapsed refractory disease.
So they had been treated before.
Yes.
Yeah.
So what we found out was that the median age of the participants was 71 years old, which is more or less what we have been seeing in all the clinical trials. So it's very similar to what the patients that participated in the clinical trials. And 16% of the patients had a comorbidity score of 3 or greater, meaning the majority of patients were kind of like a more fitter scale, like they had less comorbidities. As we age, you know that you can develop more comorbidities. We acquire more diseases as we age.
Other medical problems, basically.
Yeah. So they were, most of the patients were of the similar age on clinical trials. So when we looked at the testing rate, it was really poor, unfortunately, all across the board. In young, fit, and older patients, the FISH testing was the most commonly used biomarker testing and was still only tested in 28% of the patients, meaning only 1 out of 3 actually had the testing done before this therapy was started, which is pretty poor considering the fact that if you have high-risk markers, we always recommend to our patients to be treated with a novel agent, especially, you know, high-risk markers include 17p, IGHV mutation analysis, and 11q deletion testing. The most important one that we're concerned about is the TP53 mutation, which is the FISH analysis for 17p, or NGS analysis by TP50, you know, testing for 17p deletion or TP53 mutation. And that one was like only tested on 11% of all the patients that participated. That's, you know, like very, very low. It's 1 out of 10 really only had that testing. That's really bad in the sense that if you give a patient with TP53 mutation chemoimmunotherapy, you know that these patients are not going to respond. You're exposing them to a lot of toxicities. And additionally, you might shorten their survival. So it's very important not only for the physicians in the community, but also for the patients to know their risk markers and discuss this with their patients so that the right therapy can be offered as per guidelines.
Did you find a difference in terms of the frequency of FISH testing before treatment in academic centers compared to community sites?
Unfortunately, no. We were hoping that it would be better in academic centers, but it wasn't. It was as bad as community centers. So I guess even in academic centers, the data that supports the use of this biomarker testing is not as good, or it hasn't influenced the treatment paradigm just yet. You know, even at my center, we are a CLL center, but some of the physicians in the faculty practice would still treat without waiting for the results of the FISH analysis. Surprising, I know, but like, you know, we are our own bubble in a big system, and so not everyone is up to date on the latest and greatest information. That's why it's so important to have these educational webinars so that, you know, everyone is aware of these things.
Right. So what do you make of the notion that, you know, if you know that you're going to use a targeted agent, let's say a BTK inhibitor, that you're going to use it for high risk or low risk? So what do you say to the argument that the molecular testing doesn't matter anyway, because you're going to not use chemotherapy?
So of course, that's one of the main things that we have encountered, especially in the community, that they're like, well, it won't make any change. But what we know from data coming out, for example, from the trials for patients treated with obinutuzumab with venetoclax, which is a fixed duration treatment regimen, is that unfortunately patients with unmutated IGHV, 17p deletion or TP53 mutation end up relapsing sooner than the rest of the cohorts. So in that sense, you're still able to use that fixed duration regimen with the knowledge that you might relapse sooner than other cohorts, but it's important for the patient to be aware of this because they might want to then use a BTK inhibitor, continuous daily dosing with a BTK inhibitor, or participate in a clinical trial so that they can optimize their chances of being in remission for a longer period of time. The last thing that you want when you have a high-risk disease is to have a clonal selection that may predispose you to relapse or early relapse. So that would be the reason for us to recommend to do the testing, regardless if you are already choosing to use a targeted agent.
Yeah, and I think you bring up a good point for the audience, which is, you may be going on a targeted agent, regardless of the findings, but I do think it is useful to know if you have, particularly high risk disease, because again, maybe those are the cases where you really want to make the extra effort to go to a clinical trial. For instance, there's pretty good data now in which we combine BTK inhibitors with venetoclax, and you might have sort of closer attention to follow-up and other things if you have high-risk disease, whereas maybe if you have low risk, you might be more comfortable with a more standard approach. So I think that's a good point. So any other kind of big takeaways or kind of conclusions that you would recommend to the audience here?
So the good news is that most of the patients were treated with novel agents. As the time passed by, we recognized that ibrutinib was being selected as one of the most commonly used treatment regimens. So I think that the field is changing in the sense that most of the physicians, not only in the community and in the academic setting, are selecting novel targeted agents. As a matter of fact, amongst all the patients that were found to have a TP53 mutation, 2/3 of the patients were actually treated with a novel targeted agent. So that was good. This was also similarly found in patients with relapsed refractory disease, which is also good news. What else can I say? So overall, the most important thing is that we still have education activities to do for not only our physicians in the community, but also in academic settings, and also for our patients, because I think knowledge is power. The more that you know about your own disease, the better that you can be able to select the appropriate treatment strategy and regimen for your condition.
Very well said. I like that closing remark, knowledge is power. So that was a great overview, and clearly another kind of example of how we've seen over the years, many investigators such as yourself and others kind of coming together in a collaborative fashion to address important questions in the field. So with that, I think we can conclude, and thank you so much for talking with us today.
Yeah, my pleasure. Again,
all right.
happy to
take care.
do this again. Bye.
See you. Stay in touch.